All right, we will start with acute renal failure, where we're talking about the different, what causes it, the pre-renal, intrarenal, or post-renal. And this will be the fourth video for renal dysfunction. And let's talk about the phases. There are basically three phases of acute renal failure. Oliguria begins 1 day after the hypotensive event, or whatever the event is, and lasts 1 to 3 weeks. So there's some time goes by. Urine output may vary in volume, but the BUN plasma creatinine concentrations continue to trend up or increase. Damage impairs the kidney's ability to conserve sodium, fluid volume water excess. We have azotemia, and what that word means is nitrogen-rich compounds very high in urea and creatinine. Elevated serum levels of urea, creatinine, and uric acid, and electrolyte imbalance. Now, the diuretic phase, the tubules are still damaged, but trying to recover their function. Fluid and electrolytes need to be monitored closely during this phase, and excessive urinary loss is replaced. So very, very intense intake and output at this point we're going to be doing. Very important on these patients. Dehydration and electrolyte imbalances, a high blood urea nitrogen, which is BUN, level produces osmotic diuresis and consequent deficits of potassium, sodium, and water. This may last days or weeks. And then the recovery phase may take 3 to 12 months. So, long time for the kidney to return to normal status. Serial measurements of serum creatinine provide an index of renal function, meaning serial, we're doing them quite frequently. And they'll be monitored throughout the recovery period. Now, this is if we recover. This is what we're going to do. Oliguria, diuretic is kind of in the middle of that phase, and then recovery. It's a critical illness. Early signs and symptoms are going to be oliguria. And again, azotemia is a little scary stuff. It's blood retaining nitrogen-rich compounds such as urea and creatinine, which are waste. We cannot retain those at high levels. It can destroy other organs. It can go in our brain, crosses the blood-brain barrier, makes us very ill. Electrolyte imbalances, obviously, because it's a kidney. Metabolic acidosis. Diagnosis, blood studies showing elevated blood urea nitrogen, or BUN, elevated serum creatinine and potassium levels. Decreased hematocrit and bicarb, because bicarb's not being secreted. I'm sorry, because the hydrogen ion, they're secreting it too much, so bicarb is diminished. And hemoglobin, low blood pH, we know we're in an acidotic state. Urine studies show CAS, decreased specific gravity, so it's not, the urine's not diluted. Proteinuria, which we know there should be no protein in the urine, and urine osmolality. So treatment, what are we going to do? Well, they need a high-calorie diet, low in sodium and potassium, and they will restrict the protein because we know we've already got a problem with protein. Careful monitoring the electrolytes. Sometimes it's twice a day. Monitor the electrolytes and what we're doing. A fluid restriction because of edema, plus we don't want to overtax the kidney. Renal dose dopamine is to enhance renal perfusion. Diuretic to treat the oliguric phase. Hypotonic glucose with insulin, and because we want to get the potassium out of the blood into the cell, and here it is for more severe hyperkalemic symptoms, numbness and tingling, or any EKG changes. Sodium bicarb IV to try to treat the metabolic acidosis, because we know we're lacking that. Hemodialysis, again, because the kidney is so sick, and the dialysis can clean everything up and let the kidney rest. Okay. Interventions for nursing, again, strict intake and output. We're going to weigh the patient daily on the same scale at the same time every day. Assess the hemoglobin and hematocrit. They may need packed red blood cells. Monitor versus maintain electrolyte balance. Monitor and maintain. And then we're going to talk about chronic renal failure. Chronic renal failure is the irreversible loss of renal function that affects nearly all major organs and destruction of the renal tissue. This is if acute renal failure goes unchecked and unfixed. Progression, the nephron damage is progressive. Damaged nephrons can't function and don't recover. The kidneys can maintain relatively normal function until about 75% of the nephrons are non-functional. Isn't that amazing? I'm going to say that again. The kidneys can maintain relatively normal function until about 75% of the nephrons are non-functional. Surviving nephrons hypertrophy and increase their rate of filtration, absorption, and secretion. Compensatory excretion continues as the GFR diminishes to nothing. This may take months or years to develop, and a lot of times this is a complication to systemic, especially circulatory disorders. Renal insufficiency refers to a decline in renal function. Levels of serum creatinine and urea are mildly elevated, and usually there are no systemic symptoms. When there is significant loss, it will lead to end-stage renal failure. Kidneys have a remarkable ability to adapt to loss of nephron mass. When there is increased creatinine, urea, potassium, and alterations in salt and water balance, usually do not become apparent until the renal function declines to less than 25% of normal, when adaptive renal reserves have been exhausted. So really, really terrific organ when you're looking at these percents and it'll still function. Proteinuria contributes to tube injury by accumulating in the interstitial space and activating other proteins in cells such as macrophages, and we know macrophages are going to promote that inflammation and progressive fibrosis. Angiotensin II is elevated with progressive nephron injury, promotes glomerular hypertension and hyperfiltration caused by arterial vasoconstriction, and also promotes systemic hypertension. It also may promote the activity of inflammatory cells and growth factors that participate in tubulointerstitial fibrosis and scarring. And also, chronic renal failure increases the risk of death from infection. This is related to suppression of cell-mediated immunity and reduction in the number and function of lymphocytes and phagocytes. All hormone levels are impaired in excretion and activation. Women may be anovulatory, amenorrheic, meaning they're not having a cycle and they're not ovulating either, or unable to carry pregnancy. Men tend to have a decreased sperm count and impotence. So some of the causes, as you can figure out by knowing the pathology, is chronic glomerulonephritis, chronic infection, which can lead to chronic pyelonephritis and TB, collagen disease such as lupus. I'm sorry, this is not supposed to say lupus. This is lupus. Erythematosus, congenital anomalies such as polycystic kidney disease, endocrine diseases like diabetes. We know what those large sugar molecules are going to do to the kidney. Nephrotoxic agents such as the aminoglycosides, and we talked about that in depth for our antibiotics. That's why we have to watch renal function. And what do I mean by watching renal function? When they're on those aminoglycosides, for anything else, any of those infections that we're trying to take care of, we have to watch the BUN and the creatinine, as well as their hearing, test their hearing. Obstructions such as renal calculi, then those are stones, if they keep coming back, and a lot of times, then they are more common in men. And then vascular disease would be at the forefront, hypertension or nephrosclerosis. Clinical manifestations, hypervolemia, they have a lot of fluid on board due to sodium retention, hyperphosphate, hyperkalemia due to inability of the kidney to balance the electrolytes, azotemia due to retention of nitrogenous waste, metabolic acidosis due to loss of bicarb, bone and muscle pain because of calcium phosphorus imbalance and consequent parathyroid hormone imbalances. Peripheral neuropathy is due to accumulation of toxins, dry mouth due to hyponatremia, irregular heart rate due to hyperkalemia, hypertension due to fluid overload, muscle cramps, twitching due to hyperkalemia, and Kussmaul's breathing due to metabolic acidosis. So does this sound like a picture you want to see? No way. Hard people to manage. Really hard. They affect everything, the kidneys. So we're going to restrict the protein diet, high protein diet for patients on continuous peritoneal dialysis because it's working. The dialysis is working for them. High calorie diet, sodium, phosphorus, and potassium restriction because we know they're not getting diluted or they're not in the right compartments because the kidney's messed up. Fluid restrictions, a loop diuretic because that pulls off the fluid quickly, cardiac glycoside, Antihypertensives, insulin, may need insulin to get potassium into the cell. Avoid aminoglycosides, that would be a potent antibiotic. And our NSAIDs can cause that inflammatory response. Plus it'll promote bleeding. Calcium gluconate, we're going to treat them with. Peritoneal dialysis is they'll take it off the peritoneum. And then finally, if nothing else, renal transplant. Let's see. Kidneys cannot excrete end products of protein metabolism. It's too hard on a diseased kidney. Sodium phosphate, potassium restrictions to prevent elevated levels. Loop diuretic to maintain fluid balance. Cardiac glycoside to strengthen the myocardial contraction because we don't have potassium where it belongs. Antihypertensive to control blood pressure. Insulin aggressively control hyperglycemia and potassium levels. Calcium gluconate to protect the heart from hyperkalemia. Chronic renal failure can cause skeletal and bone alterations because of the albumin and protein problem. Cardiopulmonary system, high blood pressure and hyperkalemia can cause a heart attack. Neural function can lead to seizures. Endocrine and reproduction, we already talked about that. Hematologic alterations, immunologic, infection, gastrointestinal problems. Integumentary system, they can actually have a lot of itching due to toxins that settle in the skin that are not filtered out, and alterations in proteins, carbohydrates, and lipid metabolism. Blood test for renal function is, we've been talking about it all the way along, it's our BUN, or blood urea nitrogen, measures the concentration of urea in the blood. Urea is formed from protein metabolism and is elevated in a reduced glomerular filtration rate because it's not doing what it's supposed to do. That's what the kidney is. It's our chief filterer of the body. Normal is 10 to 20. Rises in dehydration and chronic renal failure due to slowing of fluid through the tubes. Useful in evaluation of renal disease and nutritional status. Blood urea nitrogen usually runs in parallel to pre-renal azotemia, GI hemorrhage, third-degree burns, tissue necrosis, high-protein diet, reduced GFR and dehydration, diabetic coma, fever, shock, congestive heart failure, and diarrhea. And post-renal disease would be UTI obstruction, renal vein thrombosis. So you can see what goes on in evaluating renal disease with just the BUN, how much you can tell from it. I'm going to stop right here. I thought I could get through, but I'm afraid this one won't transfer over, so we are going to have one more short video.